Hi, my name is Benjamin Bowe. I am a statistician at the Clinical Epidemiology Center at the VA St. Louis Healthcare System.
Hi, I am Tingting, a member of the Clinical Epidemiology Center at the VA St. Louis Healthcare System and Washington University School of Medicine.
And hi, I'm Ziyad Al-Aly from the VA St. Louis Healthcare System and also Washington University School of Medicine. We're here to talk to you today about our recent paper titled Association between Monocyte Count and the Risk of Incident CKD and Progression to ESRD. Now, emerging evidence suggests a role for monocytes in the biology of kidney disease progression. Patients with higher monocyte count have a higher risk of atherosclerotic heart disease, peripheral artery disease, and small cerebral vessel disease. There is also evidence from cross-sectional studies that higher monocyte count is associated with lower kidney function. However, there are no large longitudinal data examining the relationship between monocyte count and the risk of development of chronic kidney disease, rate of progression of kidney disease, and ESRD. Now, Benjamin, would you please tell us about how you approached the study design?
To address this question, we built a longitudinal observational cohort of 1.5 million United States veterans with at least one EGFR during fiscal year 2004. The cohort participants did not have any prior history of ESRD, dialysis, or kidney transplant and were followed until September 30th, 2013, or death. Survival models were built to examine the association between monocyte count and risk of incident EGFR less than 60, risk of incident CKD, and risk of CKD progression, or the composite outcome of ESRD, dialysis, or renal transplantation. Participants in this cohort were followed for a median of 9.2 years.
Now, Dr. Lee, would you please describe the main results?
We found a graded association between monocyte counts and the risk of renal outcomes. Compared to the first quartile, quartile 4 was associated with 13% higher risk of incident EGFR less than 60 mL per minute per 1.73 meters squared and 15% higher risk of incident CKD. Quartile 4 was associated with 22% higher risk of doubling of serum creatinine, 18% higher risk of greater than 30% EGFR decline, and 19% higher risk of ESRD. Cubic spline analysis showed a linear relationship between monocyte count and renal outcomes. The results are robust in sensitivity analysis. We also tested the relationship between monocyte count and the alternative outcome of severe CKD progression, defined as EGFR loss more rapid than 5 mL per minute per 1.73 meters squared per year, and the results were consistent.
Now, taken together, the constellation of findings here suggests a significant association between higher monocyte count and risks of incident CKD and CKD progression to ESRD. One simple explanation of the observed associations is that monocyte count may be a mere surrogate marker of inflammation and poor overall health, and thus higher risk of adverse long-term renal outcomes. However, this association ties in very nicely with the experimental findings of a role for monocytes, chemokines, and chemokine receptors in the biology of kidney disease and its progression. Further studies are needed to determine which monocyte subtype exhibits the strongest association with or best predicts renal outcomes. In addition, more experimental and clinical investigation is needed to better understand the biology of monocyte in kidney disease and translate this understanding into opportunities and therapeutic avenues to halt kidney disease progression. In sum, our results demonstrate a significant association between higher monocyte count and the risk of incident CKD and CKD progression to ESRD. These findings provide epidemiologic context to enhance our understanding of the experimental observations of a role for monocyte in the biology of kidney disease and its progression. This concludes the CJASN podcast. Thank you.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.